Introduction to Nursing Concepts, Hydration and IV Therapy Part 5. This is Martha Olson with Iowa Lakes Community College. When we look at our IV administration, there are several ways we can go about doing that. The IV piggyback is also called a secondary. It's given a small amount of med, usually 50 to 250 milliliters of fluid that's run in with the medication that you have put in. Antibiotics are probably in your hospitalized patient the most common, but we can also use other medications as a piggyback. Your IV push or bolus is a short amount of time that the medication is given into the vein, and we get immediate results because it's right there in the vein in the circulation. And then our continuous is usually to give fluids to rehydrate, to keep the vein open. As we look at each one, we know that when we add meds to any kind of IV bag, we have to make sure that we agitate the bag to mix the medication well. Otherwise, they're going to get a whole lot of medication in a little bit of fluid. Our IV piggyback is initiated after the primary IV is infusing. Use the first injection port below the check valve, and it must be suspended higher than the primary bag in order for a piggyback to infuse, and that's because it goes by gravity. The bag that's hanging highest is where the bag will pull from, and so we put the piggyback higher, put the primary continuous infusion lower, and it will pull from that piggyback bag. With IV push, Potter and Perry talks about how the IV push can be very serious because there's no chance to get it back. Once it's there, it's there. It's given directly into the tubing. You wipe it with your port with an alcohol wipe, administer the med, and oftentimes then we will flush with a normal saline flush to get the med out of the site. We make sure that it is drug compatible, that we have a doctor's order, that the amount of the drug to be infused. So if I was giving Lasix and it needed to be given over 5 minutes, I either have to push it very slowly or you mix it in 10 milliliters so that you can give smaller increments throughout over the amount of time that it's to be given. When we think about IV push, we know it's manually administering the medication over a short period of time. That would be cardiac meds. That is the patient in the ER that's frothy and in severe congestive heart failure, where we are giving maybe Lasix or something we want to get to them very quickly. We have to check drug compatibility, because if the continuous infusion has potassium or blood or something hanging, we can't just put a piggyback or a push into that site. We have to check for either starting another site or stopping the IV and then giving the bolus, flushing, and then hooking the other one back up. With the continuous, it's usually a large amount of fluid that's infused over hours or days to maintain a drug concentration or to rehydrate with that. As we look at this piggyback, you can see then that the medication is hanging above the primary IV so that gravity will pull it. Many of our newer pumps also have the ability to set it so that it will run in the 50 mils of the piggyback, switch its rate over, and then start pulling from the continuous IV. When we look at our IV tubing, it comes in different sizes. Usually we use the macro drip. On the outside of the IV tubing bag, it will tell you how many drops per milliliter that tubing is, and that's how you calculate your drops per minute using that number. Your micro drip is 60 drops per mil, usually used only in pediatrics. They're also called like a Soluset, and it's kind of a safety mechanism because we want to get the exact right amount of med in. So you would use then the micro drip. Our secondary is what we see hanging higher with the IV piggybacks, usually antibiotics, and those then get back primed, and in lab you will learn how to back prime to be able to flush the meds or get the meds through that in order to keep the tubing without opening and flushing to keep it closed. When we look at other types of tubing, our Y tubing is for blood administration, and then we have for pediatrics a volume controlled IV tubing where you drop a small amount of volume down into that secondary tubing that allows you to then check that IV and check to make sure that we don't get fluid volume overload in very young pediatric patients. When we change the tubing, Potter and Perry talks about that as to think about what is running in there. If you remember back to the nutrition unit where the kangaroo tubing with the TPN or the Gevity tubing feeding was changed every 24 because it's sugary and it grows bacteria. With our primary and secondary sets, it's per protocol of the facility you're working at, but because it doesn't have sugar, usually every 3 days is standard for the sets to be changed. We label them with a label so that we know when the IV tubing was last changed and when it now needs to be changed again. Central lines, because of the high risk for infection, every 24 to 48 again, depending on the protocol of the facility you're working. With the blood tubing or the Y tubing, it's typically after each unit of blood because all of those cells in there and going through that special filter tend to plug easily, and we oftentimes, if we try to run a second unit of blood through that same tubing because it's been given concurrently, oftentimes it will plug, and it's just sometimes easier to get new blood tubing or Y tubing every time you hang a new bag. When we would warm fluids, think of patients that might be cold coming into the ER when they've been out in a snowmobile accident, or also like in your OR where the patient might be cold. So there are times we also warm IV fluids. Some of the add-on devices we see, a stopcock is used to direct the flow. Most of the time stopcocks are used by the anesthesiologist back in surgery, so if they need to give a medication, they just turn the stopcock, which you can see in the next picture, and how then they are able to kind of, it's an on and off button, so they can intermittently inject medications into the line. The extension sets then add length and additional medication ports to the primary tubing. They aren't usually used routinely, but sometimes we see extension sets that are put on back in surgery and they come back to the floor with them. Our infusion caps are used to convert a continuous infusion to an intermittent, an IV to a saline lock, and so an infusion cap would allow you to put medications in but also keep the environment, the dirt, the germs out. Our filters, the purpose is to eliminate air and particles of a certain size that should not be infused into the patient. We see filter used with TPN. Some of our blood always has the tubing that's filtered. They can either be a single unit or attached maybe to the IV tubing, such as the blood tubing. Our needleless is standard today because of needle sticks. All of our devices have gone to the needleless access, so we aren't using needles. If we have to, they usually have just a little puncture site to them that you've probably used to puncture into the containers. And then as we look at our infusion pumps, they come in different ways and different types. And when we use the infusion pumps, they help us regulate, but you also have to go back to, did it seem right? Because an infusion pump is a machine, and machines do falter or make mistakes. So if you hang 1,000 of normal saline and you think it's going at 100 an hour, it should last 10 hours, it'll be done at 6 p.m. tonight, and at 2 in the afternoon it's done, you need to take it off of that infusion pump and have it sent down to be checked, to be recalibrated, to make sure there isn't something wrong with that. So this is a stopcock. Again, it's the on and off that you might see anesthesiologists use so that they can administer medications into the patient during surgery. This is our extension tubing. The advantage to this is it gives a little more length to it, but also you can see then it has an extra port, so if I need to give an IV push medication, I've got a port that's very close to the patient's vein and would be administered very quickly. These are the infusion caps that I talked about. We would use these. You can see we wipe them off with alcohol. You would put the medication then into the infusion cap so that we do not have to have an open system. I don't have to unhook the tubing and give a med and then rehook the tubing, opening that up to a higher risk for infection. The filters, as I discussed, are here. We can see the filter for the blood. They filter out particles that we don't want them to have, and so they are a kind of a safety measure for us as we give things. Blood is your most typical type of product that we use a filter for. And then our needleless devices prevents sticking of ourselves and needle sticks where we have to make an incident report and all of that. You can see, as I was trying to describe a minute ago, they have the little blue pointed end that would pierce then through that multi-dose vial, enabling me to use that without having to have a needle. And lastly is our infusion pumps. They all come in different things. When we look at the infusion pumps, I know Spirit Lake uses one that has what we call a plum set. They all work about the same. The one in the top right corner is a double pump. So if I was in the unit or in OB and I had a patient that was having complications, I would anticipate that one side would be hanging maybe dopamine and the other one would be IV fluids to help get their volume up. Each one has its own separate brain that I would turn it on, be able to set the rate. I can clear it at the end of my shift and it clears the pump so that the next shift starts out with a zero balance and you can take your IV intake right off of this pump. You have to prime the tubing before you put the tubing through any pump. They all work just a little differently, but once you kind of get the hang of one, they all kind of work about the same. They alarm when they're unhappy with either the patient has tubing that is kinked off, maybe their IV is occluded or is infiltrated and it's not able to run in. It will alarm and tell you when your bag is empty or almost empty if you have air in the tubing. And so you have to be able to troubleshoot what it says on the screen and be able to look and see what possibly could be causing this infusion pump to be alarming so that I can fix it correctly. The button that you want to learn first of all is the silence button, because it's very hard to distinguish or figure out what you're doing when that thing is beeping at you and it's also bothering the patient that's trying to rest. It gives you then just a little bit of time to be able to stop the pump and figure out what you need to do. If you hang new tubing, typically it is air that has gotten in that tubing that it will alarm. And so when you go to prime your tubing, you'll want to make sure the first thing you do is turn that roller clamp off, that you squeeze the drip chamber to get it half full, and then very slowly open your roller clamp to allow the fluid to infuse or go through that tubing, turning your caps over so that you get the air out of the injection port caps, and then trail it on through. You can do that in the med room, where it's easier to concentrate and to be able to flick it and focus on getting the air out. If your patient has a very positional IV, it may also alarm at that time telling you that maybe they bent their arm and the IV is occluded just simply because it's in the antecubital space and they've bent their arm. So in looking at review of this PowerPoint part number 5, we think about the IV piggyback as a small infusion of a medication given. We think of the IV push as that medication is given very over a short period of time. Read your drug books. Look in there under nursing implications where it talks about the fact that this IV push of Lasix is given over 5 to 10 minutes. If you give it too quickly, IV push, you will cause them to lose their hearing, possibly with cranial damage to the 8th cranial nerve. Each one will tell you how it's to be administered IV push. During a code blue, there is a drug called adenosine that has to be given as quickly as possible, followed with a very fast normal saline flush, because its half-life is about 45 seconds. And if you don't get that med to the heart in that 45 seconds, it will not be effective or work. And then with our continuous infusions, you're going to want to use your critical thinking about the rate that the doctor has prescribed. Is that appropriate? If it's a peds patient, it's going to be much slower than an adult. If it's a person that's hemorrhaged and has a large bore 16 or 18 IV site, you may be giving IV fluids at 100 or 500 an hour to get them out of trouble with hypovolemia. So each situation you have to kind of take into consideration. We will be talking a lot more about blood infusion in the next PowerPoint slide coming up, where we look at the tubing with the filter. This ends part 4. Thank you.